Hello, everyone. A big hello to all the students and all the viewers who are watching this evening. And we are going to see yet another session of mixed match. Okay, so here we are going to see, and this is number 7, mixed match series in anatomy, number 7. So here we are going to not just look at the MCQs, but also we are going to look at some scenario-based questions. So scenario-based questions always gives you a little more information because it will have sub-questions. So it will have sub-questions and some picture-based things and everything will be included. So that way you are going to have a little more thinking to do than the regular MCQ questions. Okay. So here, this is what we are going to do. So always you should remember just the MCQs without understanding the subject is not going to help you because solving the MCQ just for that moment, it will be fine. And it is that happiness is just momentary. Next moment, when you try to, solve some other question, it could be relevant to the same thing. The key words you have to pick, and then it could be something very similar. You will get stuck because you don't know the basics of the particular topic. It's always important that you understand the topic thoroughly and then you try to get the keywords and then try to solve the question. Okay, so here we are going to do something similar. You're welcome to Unacademy. I'm Dr. Rohini and you are watching Gross Anatomy. And the subtopic is Mixed Match Anatomy Series 7. Okay, so here is my credentials. I have anatomy from KMC Mangalore, that is located in Karnataka. Okay, sorry about that error code. There was the issue with the relay. So this is the question. A 50-year-old man comes to the physician because of the swelling in his groin. So we have to underline whether it was a male or female patient. 55-year-old man. Okay. And then the next keyword is groin. You have to remember that. And then the physical examination showed that there is a bulge above the inguinal ligament. So where is it? It is above the inguinal ligament. And also it increases in size whenever the patient is having a cough. And he's referred to a surgeon and he's to undergo an elective laparoscopic hernia repair. So we already know that it is an hernia. And what kind of hernia is this? We already know that there is femoral hernia, there is direct and indirect inguinal hernias. So which one is common in whom? All that we need to find out. Which of the following landmarks will best aid the surgeon in distinguishing an indirect from a direct inguinal hernia? So one thing is very important. The femoral hernia are more common in case of females because of their wider pelvis, because of the way the bone is shaped and because of the way that it is, kept in place. It is more common in case of females, femoral hernia. And that happens through the saphenous opening. So please remember, femoral hernia happens through the saphenous opening, where the great saphenous vein is supposed to join the femoral vein. Okay, that is where the great saphenous vein joins the femoral vein. So that happens more in female. You remember this F for female. Okay, so that's how I would suggest you to remember. Some key things you should learn quickly. Okay, so this is how you remember the femoral hernia is more common in female. And then coming to the male. So in this particular case, it is the male, 55-year-old male. So in male, what is more common? It is the inguinal hernia. Inguinal hernia is more common. And inguinal hernia, the name itself implies it is above the inguinal ligament. And above the inguinal ligament, we have superficial and deep inguinal rings. Okay, superficial and deep inguinal rings. There are two rings. And there is a connection between them, and that is called the inguinal canal. The inguinal canal is present connecting the superficial and the deep inguinal ring. And then that, if there is a structure passing through the deep inguinal ring, then you would call that as indirect. And if there are structures entering through the abdominal wall, or punching through the abdominal wall, anterior abdominal wall, you would call them as direct. And that is through a triangle known as Hasselbalch's triangle. Hasselbalch triangle. Okay, so this is the way anybody would normally teach. But do you know where is inguinal ring? In which layer of the anterior abdominal it is? How many layers are there in the anterior abdominal wall? Have you got any idea about these? And because it is very easy to get the answer and just get away with it. But if there is some other question that is asked, keeping this particular topic in mind, will you be able to answer? So all these questions are something that you need to address. So because unless you have understood the topic, it becomes very difficult. Now I can easily tell you in this case, so which of the following landmarks will best aid the surgeon in distinguishing a direct and an indirect inguinal hernia? So direct and indirect hernia, you should remember it is above the inguinal ligament. So the the question itself told you a bulge was above the inguinal ligament. So it was a inguinal hernia. And there are two types. One is deep and another one is deep passing through the indirect form. And then there is a direct one which punches through the anterior abdominal wall. So what are the boundaries of these two we have to know? So keeping in all this in mind, I would just say that the answer is inferior epigastric vessels. But how did I arrive at this? Let's go to the question itself and let's see a little more in detail what are the layers of the anterior abdominal wall. All right. So here we have all these structures. You can see there is a deep inguinal ring. There is superficial inguinal ring. This is the superficial inguinal ring. And this is the deep inguinal ring. All right. So coming to first of all, what are the layers in the anterior abdominal wall? Anterior abdominal wall has 8 layers. Okay, if you remember all these 8 layers. So if you ask any UG or a PG student, the first thing that he will say is skin, right? The first layer that you will see is a skin. And then would be the, from outside to inside, I'm saying there is a skin and there is superficial fascia. And there is the next one, external oblique muscle. Then comes the internal oblique muscle. And then transverse abdominis muscle. Then comes the transversalis fascia. Okay, next comes the extra peritoneal layer of fat. You must be wondering why we have so much fat in the abdomen. That is because of this layer, extra peritoneal layer of fat. And the last one that covers the abdomen is the parietal peritoneum. Parietal peritoneum. So all these 8 layers. So these are the 8 layers that if you count 1, 2, 3, 4, 5, 6, 7, 8 layers. What is that one thing that you don't notice here? There is no deep fascia. There is no deep fascia. Why there is no deep fascia? Deep fascia is not present in the anterior abdominal wall. It is not present in the face also. Why it is not present? In the face, the muscles are attached to the skin. That is the reason the deep fascia is not present, because the muscles will move the skin and it gives you the expression on the face. All right. So that's the reason deep fascia is not present. So when deep fascia is present, it wraps around the structures and it makes it immobile. So now here, if the deep fascia was present in the anterior abdominal wall, it would have been very difficult for the abdomen to descend. So abdomen has to distend. Okay. So because of this reason, during pregnancy and also when there is a other reason, for example, physiological or a pathological reason. So there is a physiological reason or a pathological reason like ascites. So these conditions, the abdomen will distend. When such a thing happens, if the deep fascia is present, it will not allow the abdomen to distend. That is the reason there is no deep fascia. There is no deep fascia in the anterior abdominal wall. So keep this in mind. And this has been asked many times in the exam. Last year itself, in the August 2020, it was asked. So this question, is deep fascia present in the abdomen or not present in the abdomen? So that is one question you have to remember. All right, so now here, these are the layers. And here you can see there is a deep inguinal ring and superficial inguinal ring. So what you have to remember is, this was asked on 1st August 2020. So this was the exam, I remember now. Okay, 1st August 2020. So now here, external oblique aponeurosis. So now there is two things. One is, okay, so now there are two things. There is transversalis fascia. So this is one. This is, I'll use a different color because you'll not be able to appreciate the, writing. Transversalis fascia. Here is your deep inguinal ring. Okay, where is the deep inguinal ring? The deep inguinal ring, let's circle that. And this is present in the transversalis fascia. See, this is the transversalis fascia. So these two are together. All right. So this is where it is. And where is the superficial inguinal ring? So this is the cremasteric muscle, superficial ring. This is the superficial ring, but where is it? Superficial ring is present as a triangular shaped opening. Okay, this is a triangular shaped opening and it is present in the external oblique aponeurosis. Okay, so this, what about this one? What is the shape of this? It's an opening which is the, oval in shape. It's oval in shape and this is triangular in shape. And this information is very, very important. Which one is oval, which one is triangular is very, very important. So keep that in mind. And then next one, you can see the canal that extends from the deep inguinal ring to the superficial inguinal ring is known as the inguinal canal. So it is present above the inguinal ligament, as you can see, and the deep inguinal ring, if the structures pass through deep inguinal ring and exit out through superficial inguinal ring, it is known as indirect hernia. So this is indirect hernia. All right. So that is indirect hernia. There is one more hernia that is called direct hernia. So direct hernia actually is present on the lateral aspect of the rectus muscle. Lateral aspect of rectus muscle. Rectus abdominis muscle. Okay. So rectus abdominis muscle, take that as the, landmark. This is the lateral aspect. Here you just draw a line and there are other structures like the epigastric vessel. So you can see there is an inferior epigastric vessel. So you can see this as the inferior epigastric. Inferior epigastric. Right? And there is one ligament here that is called the Poppert ligament or the inguinal ligament. So you remember this rectus, inferior epigastric, and P as a Poppert. So what did you get? You got RIP, rip. Okay, RIP. So this is the boundary of this triangle, which is called the Hasselbalch's triangle. Hasselbalch's triangle. So this triangle is very important because the direct inguinal hernia happens through Hasselbalch's triangle. Direct inguinal hernia. So these are the two types of hernia which are more common in case of male, and in the case of female, the femoral hernia is more common. So now, according to you, which one is the landmark or key thing that actually gives you a differentiation between the direct and the indirect? So that is the inferior epigastric vessel. Why? Because on the medial side of the inferior epigastric vessel, if there is a, punch through the wall, then you call that as direct inguinal hernia. If it is on the lateral aspect, you would call that as indirect hernia. Okay, so inferior epigastric vessel is the landmark. So keep this landmark in mind, and the landmark is inferior epigastric vessel. So if you go back to the question, so here is the A, the answer is A, okay? So do you see how much time it took? So if you have already practiced once, and if you have a rough idea about, what is the landmark that we need to keep in mind to distinguish the direct and the indirect, then it would be inferior epigastric vessel. Indirect is lateral to inferior epigastric vessels, and this direct is medial to inferior epigastric vessels. As simple as that, actually. But if you are not aware of the question, if you are not aware of how the question could be asked, then it becomes a messy thing to recall. All right, next one. Okay, so here we have some of the nice questions. And before that, I also wanted to tell you how long is this inguinal canal. It is inguinal canal is about 4 centimeters. 4 centimeters, and it lies medial to the inguinal ligament. All right, so this is something you need to remember. So when you join the deep and the superficial inguinal rings, you get the inguinal canal. All right, so with this information, let's move on to the next question and see what we have next. So here is some of the derivatives that we can see from the various things. So we have malleus, incus, Meckel's cartilage, and whatnot. We have many, many things. Let's see this. All right, so here. Let's see if there is anyone who has any questions. Yes, Ajit, you are right. You have been answering the questions. The answer is A. I hope you also understood how to justify your answer. Always it's important you learn to justify your answer. Correct? So here is the next one. Let's see some of the derivatives from the arches. So we have arch 1, 2, 3, 4, and there is no fifth. No fifth. Okay, this is not there. So let's see what are the derivatives. We have malleus, incus, all these are derivatives from the first arch. Malleus, incus, Meckel's cartilage is the cartilage from this arch, and then we have the nerve, mandibular nerve, and arteries, maxillary artery. And coming to the second arch is also called the hyoid arch. The first arch is also called mandibular arch. Okay. So here we have stylohyoid ligament, stapes, lesser cornu of the hyoid bone, upper body of the. So you can say that the hyoid bone, if this is the hyoid bone, you have just this portion. I'm just going to use a different color and show you. That is what is derived from the second part. That is the lesser cornu of the hyoid bone and also upper portion of the body. This is from the second arch. All right. So lower portion, that is from the third arch. Let's put it in green. So this is from the third arch. This is third arch. That upper portion is from the second arch. It looks almost like a boat now. So we have facial now for the second arch, and we also have stapedial artery. Okay, third one is the, arch that has no name, no particular name for that, and lower part of the hyoid bone and also greater cornu of the hyoid bone you can get as a derivative. And the nerve of this arch is glossopharyngeal and common carotid, internal carotid. All these are the derivatives. And you can also see the fourth one, thyroid cartilage is the derivative. You can see the superior laryngeal nerve. That is a branch from the vagus. That is the nerve of the arch. And also the arch of aorta and right subclavian artery. And here you can also see there is no fifth one. There is no fifth. and that gets regressed. Okay, that gets regressed. So it is not existing at all. But you have the next one, that is the sixth one. It gives rise to all those laryngeal cartilages. So here you have the recurrent laryngeal nerve as the nerve of this arch. Remember, here superior laryngeal, here recurrent laryngeal. So vagus is completely into the fourth and the sixth arches, fourth and the sixth arches. So here you have to remember this all as the 5, 7, okay? 5, 7, 9 and 10. All these are special visceral efferents. All these are special visceral efferents in the component. So remember, all these are special visceral efferents, SVEs. Okay. So this is important. Fifth one, the mandibular is branched from the trigeminal, facial, glossopharyngeal, like a phone number you remember, 5, 7, 9, 10. So these are the nerves of the arches. All right. So here it is an easy method I've told you to remember, and like a phone number you remember, and also remember these are special visceral efferents. And here are some of the aortic arches and arterial structures. Now, first arch, if you just want to summarize quickly, summarize everything. So you have first arch, you have the maxillary artery. Second arch, what is the artery? You have the hyoid. And then third arch, you have common carotids. And fourth arch, you can see the subclavian and left aortic only, because the right one does not come there, left aortic only. Then there is the fifth arch. Fifth arch, you have regressing completely. It regresses, so it doesn't exist. Okay, keep that in mind. Next, sixth aortic arch has the pulmonary vessels. So these are some of the things that you have to remember, and these are the derivatives of the aortic arches in terms of arterial structures. All right, so let's go to some of the structures that are derived, of the ear. Now we'll talk about various other structures also, but let's just look at only the ear, because this one is very important. And the first and the second arch is most of the structures are affected in which syndrome? It is affected in a syndrome called Treacher-Collins syndrome. So this syndrome affects the structures derived from the first arch and the second arch. So what are the structures? If you know what are the structures that are affected, then it is easy to appreciate. So what is that is affected? Auricle pinna. Okay, that is derived from the first and second arch. There is external auditory canal, that is from the first arch. Tympanic membrane. Tympanic membrane has outer, middle, and the inner. So all the three germ layers are involved in this formation. So keep this outer, middle, and inner part has three different, structures. So all the three germ layers are involved in making or embryological origin. All the three germ layers are. So now here we have the malleus and incus. Remember M for the first arch, that is mandibular arch. And then you have stapes. Remember S, that is from the second arch. Okay, that is from the second arch. And then we have the foot plate and annular ligament, that is from the otic capsule. That is from the otic capsule. And then we have tympanic cavity. Tympanic cavity is from the first pharyngeal pouch. So first pharyngeal pouch. So you have to remember these. So the otic capsule, what you saw here. So otic capsule is it's a capsule. It's not a vesicle. So remember, keep this in mind. It's not vesicle, it's a capsule. So you have to remember the membranous labyrinth. Membranous labyrinth is from the otic vesicle. Okay. This stapes, foot plate, and annular ligament is from the otic capsule. So which one is from capsule? Which one is from the vesicle? You have to know. So here it is the membranous. So this one is from the capsule. So bony is from the capsule. So bony structure is from the capsule. All right. And we have the membranous is from the vesicle. So keep that in mind. Membranous is from the vesicle and bony structure is from the capsule. And then we also have this particular syndrome that we have to highlight because that is what shows all these first and second arch defect. Treacher-Collins syndrome. So particularly the striking feature that you will see is the face looks like bird. Okay, bird's face. And the main defect you will see is in the ear. And also you can see the coloboma of the eye. So it is drooping eyelid. So you can see all these things in the Treacher-Collins syndrome. So that is one important thing you need to remember. Other than that, you have semicircular canals and utricle, saccule and cochlea. These are from the parts superior and inferior. So out of all these, if somebody asks you what is very, very important, I would say the tympanic membrane. Okay, tympanic membrane is very important. The malleus and stapes is very important. And also the external auditory canal is from the first arch. The opening is from the pouch. And then you also have the eustachian tube that is from the pouch. This is what I was talking about. Tube is from the pouch and auditory canal is from the arch. So keep the difference in your mind and learn accordingly. So here is the next question where you have a very neat question. So here a 31-year-old, okay, female is injured in an accident. It leads to fracture of the shaft of the humerus. Remember, it is the shaft. Okay, later on examination, what happens? There is loss of cutaneous sensation. Loss of cutaneous sensation on the anatomical snuff box. Okay, anatomical snuff box. There is lack of sweating also. So sweat glands, that also is supplied by cutaneous supply. On the back of the forearm. And there is wrist drop. The moment you see the wrist drop, we have to remember we are talking about the radial nerve. Okay, radial nerve. So that is what leads to wrist drop because radial nerve is the only one which supplies all those extensors in the arm region and forearm region. So, okay. So we have to remember the radial nerve supply. So now here enumerate the neurovascular structures most likely injured in this case. Describe the origin branches of the affected vessel. Describe the origin, root value and course of the affected nerve. Explain the anatomical basis of above clinical findings. So this is the question. So what is the neurovascular structure most likely injured? One is the radial nerve. And the radial nerve is always accompanied in the radial groove by profunda brachii artery. And you can also see the branches affected you can talk about. We'll talk about this in detail. Describe the origin, root value, course of the affected nerve. We are going to tell about the radial nerve. And we're also going to talk about the anatomical basis of the above clinical findings. What is the anatomical basis? Okay. So let's see how the question could be, answered. So now here is the first one. Okay, here is the first one. Enumerate the neurovascular structure most likely injured in this case. The most likely neurovascular structure injured in this case is the radial nerve and the profunda brachii vessels. The nerve accompanies this in the shaft, okay, where there is spiral groove. This is the spiral groove. and you can see the fracture in the spiral at the spiral groove. So that is what you can see. It's on the posterior aspect of the humerus. And the origin and branches of the affected artery, if you look at the artery, is profunda brachii artery. So profunda brachii artery is one of the largest artery that is given from the brachial artery. So it arises just below the teres major muscle. So teres major muscle, you can see this is the teres major muscle. Just below that, you can see there is a brachial artery, and that gives this artery the profunda brachii artery. So now here it continues its journey and it gives lot of branches. The branches are, there is, it also pierces the lateral lateral interventricular septum. Hold on. Sorry, the lateral intermuscular septum, IM septum, intermuscular septum, and then it gives so many branches. Okay, now let's talk about all those branches and what is their role. So you have the anterior and posterior branches. You can see anterior descending branch, which is actually the continuation of the profunda brachii artery itself. Okay. So anterior one, which is also called the radial collateral, it is supposed to be the continuation of the profunda brachii artery itself. There is also middle collateral, which is called posterior descending. Posterior descending actually pierces the triceps. It passes between the triceps, okay, to form an anastomosis around the elbow. And there is also deltoid branch. So you also see the deltoid branch. It also passes between the triceps. It also passes between the triceps and it descends down. It descends down to, anastomose with the posterior. It actually anastomoses with the descending branch of, hold on, descending branch of posterior circumflex humeral artery. All right, so that is what it does, the deltoid branch. Next, you have the next you have the nutrient artery. What is this nutrient artery? Nutrient artery is always given by the brachial artery itself, but sometimes there is also accessory nutrient artery. Here in this case, it could be present, and that is a branch of profunda brachii artery. Okay, that is the branch of profunda brachii artery. So this is an accessory one. It may be present. All right, so this is the branches that is from the profunda brachii artery. So all these branches could also be affected. All right, let's see what we have. The third one says, describe the origin, root value, and course of the affected nerve. So now what nerve is affected? The nerve that is affected is, as we discussed, it is the radial nerve. So radial nerve is what is affected, and we have the root value C5, C6, C7, C8, T1. So this is the root value. All the roots are there. All roots take part in formation of the root value of radial nerve. And it is the largest from the posterior cord. The other one is the axillary nerve. And the important nerve is the axillary nerve. And the cord says it runs behind the third part of the, this is the one which it runs behind the third part of axillary artery because it wants to go to the extensor compartment, and it lies in front of subscapularis, latissimus dorsi, and teres major muscles. And in the upper arm, it lies behind the brachial artery. And then here it passes, here very closely in association with the profunda brachii vessels, that is in the shaft. And you can also see that nerve. Here you can see that it is seen in the spiral groove. It enters the spiral groove, and that is also called the radial groove. And you can also see that it lies between the two heads of the triceps, and the lower end, it reaches the lateral side of the arm, and just 5 centimeters above the deltoid tuberosity. You can see that again. So it pierces the lateral intramuscular septum here, and that is how it enters the anterior compartment of the arm on the lateral side. So here you can see that it is between the brachialis and brachioradialis. So here it lies across the lateral epicondyle of the humerus, and it is also seen in the cubital fossa. All right. So here it terminates by dividing into superficial branch and the deep branch. So here the superficial branch is what we were talking about. It supplies all those cutaneous supply. All right. So we'll see what are the cutaneous supply. So here the cutaneous supply is by the superficial branch of radial nerve. So here it supplies not just the skin, but it also supplies the anatomical stuff box area and also the sweat glands in that area. So that is the reason in the question itself, the patient had loss of sweat. Loss of sweating was there, and there is also loss of sensation in the anatomical snuff box region. So that is because of damage to the radial nerve. So here you can see so many branches in the axilla. You can see the cutaneous branches in the radial groove. You can also see on the lateral side of the arm. You can see deep branch, what all it supplies. It also supplies the supinator muscle. Remember, the superficial branch, it supplies the anatomical snuff box and also all those areas on the dorsum of the hand. You can see this is the region the superficial branch would supply. So you can see the anatomical snuff box lies here in this region, and that's the reason it lost the sensation. Okay, because of damage to radial nerve, and so is the damage to the superficial branch of radial nerve. So you must remember which branch of radial nerve supplies the cutaneous supply. So that is the answer. So here also you can see the space between the first and the second one, that is the distribution, sensory distribution and branches and distribution of the radial nerve you can see. And with all these things, you should be able to see what is the effect of the damage to radial nerve if there is a fracture of shaft of the humerus in the region of the spiral groove. So these are the set of things that you can typically observe in a patient. So he will show weakness of extension of the forearm at the elbow joint, not complete loss, because there are other muscles also which could be, assisting. So there is only the weakness at the elbow joint. Extension is not possible. And there is also sensory loss over the narrow strip of skin here on the back side. This is the skin, the narrow strip of skin on the back of the arm, elbow, and also the forearm. That area has loss of sensation, sensory loss. And also the 3.5 digits, except that over the proximal phalanges. All these tips are fine. Tips of the fingers are fine, but up to the last interphalangeal joint. Then, as the nerve also contains sympathetic postganglionic nerve fibers, and they're all located in the sympathetic chain. These supply the sweat glands. So here there is also loss of sweating in this region because of that reason. So cutaneous nerve also has sympathetic postganglionic fibers. Always you remember sympathetic supply is for the smooth muscles. Smooth muscles are also part of the sweat glands. That's the reason there is loss of sweating in that region. So here you have to remember some of the other important main features, that is wrist drop. So if there is a damage to radial nerve, one of the important key things that you will notice in the patient is the wrist drop. Okay, so you can see there is no extension at the wrist because of the extensors of the wrist are supplied by the radial nerve, and its posterior intraosseous branch is affected. That's the reason the extension is not possible. So wrist drop is quite disabling And because the patient cannot grip any object firmly by his hand without any action of the extensors, you can easily make out that the patient has inability to do such actions, and definitely there is a issue with the radial nerve. All right. So here is all those important things that we wanted to, discuss today. And these are some of the profile picture dedications from my favorite students who have always been with me. And there are so many dedications on the Teachers' Day as well. Thank you so much for all the love and affection, and also the dedication that you have towards your studies. So here it is, the Telegram channel. You can join the Telegram channel. Let's crack NEET PG. Okay, you can join this, and you can also join Anatomy by Dr. Rohini. And when you join this, you will be able to discuss any more questions, queries, in case you're not able to, get it clarified during the session. You can always approach me with your other questions and queries. So all this can be done. If you have any doubts regarding the subscription, please do contact me. And here it is, the subscriptions. There are iconic and plus subscriptions. And you can also see there is a feature called Ask a Doubt. You can ask the doubt, you can clip the question, you can post your question, ask a doubts. And here is a free Unacademy printed notes with plus subscription. So here this can happen, only 4 days are left. Okay, yesterday was 5 days left, today is 4 days left. So countdown has begun. So here is the 4 days left. Within 4 days, if you subscribe to plus subscription, so you will be getting free Unacademy printed notes. So this is going to be very useful for all those who are exam goers, and also those who are planning to take up the exam in near future. So you will have all the 19 subjects there, and please subscribe today if you want to avail this offer. So only 4 days left. The countdown is just 2-3 days more, and your exam is on 12th. And to subscribe, you can definitely use my code ROHINI 10. So when you use this code, you will also get the 10% discount. So try this. It's really, really worth it. This is the Wednesday class, that is tomorrow. I'm going to start the first class at 7:30 in the morning. It's AM. Okay, please note. With the nerve, I hope you got it. It is the vagus. And we also have at 6 p.m. another class with the glossopharyngeal. Sorry, this is going to be histology. Okay, it's going to be histology. The histology slides, most of them struggle to identify. I'll tell you one nice trick to remember the histology slides. And there is also another class at 8 p.m. which is going to be glossopharyngeal. I'm going to tell all the key things about glossopharyngeal. You never have to go back and look at glossopharyngeal again if you know these key factors that you need for the exam. Okay, so all this with Dr. Rohini on 8th 9 2021, that is tomorrow morning, as early as 7:30. Please log in and be there. And special classes, how do you get there? You can use this code ROHINI 10. This is the unlock code, and you can get there by downloading the app, Unacademy Learners app. So once you download the app, go to competitive exams, then go to NEET PG section. There you please see, look for my classes, enter the code. Okay, enter the code. My name, I'm Dr. Rohini. And once you see my classes, upcoming classes, you will be able to enter the code. Once you enter the code, you will be notified about all my classes whenever it is held. So you are in. So you are into the circle. And this is absolutely free for you. Please make use of anything that comes your way for free, because that is something that is going to really motivate you to do better. And you may also, get even more better things with the subscriptions. And this is the feature of special classes. It's very interactive. We use polls. There is a feature called raise a hand. You'll never miss a class because you get all the notifications. And there is also lecture notes that is available at the end of the class. And you also get to watch this anywhere, anytime, because you don't need a laptop. You just have to have a simple gadget where you can just, have the app installed, and watch it. And these are some of the steps to subscriptions. And you can also see there is install app. How do you install it? Just go to Google Play or App Store and find the app, install it. And this is a Focus FMG batch for FMG 2021 starting on 8th. That is, duration is 3 months. Please look up all those features that this has. It's really worth going for the subscription. And also we have Target Next 2022 batch starting on 8th. And this is a proud star learners. So these are some of the students who have scored such high numbers, and they have really made us proud and everyone proud at Unacademy learning platform. And there are many, many more which cannot be displayed here. So please go up to the website and look up all those pictures. And we have another feature that you can, check out, Bugs Bounty, and where opportunity is given for all the learners to report anything inappropriate. And we urge you to like and share always. And please subscribe and always download the PDF notes after your special classes. And this is the referral code. This is the referral code, ROHINI. You please don't forget this code. You get a discount as well as you get the freebies. So many things you can get with the referral code. So you use this as unlock code in the whenever you are a first time user to this special class, you must have a code with you in hand. So keep this in mind. It's my name and just add 10 next to it. All right, here you get the plus subscription features and also iconic subscription. These are the features. There are batches started on 18th. It's going to go on till the mid-September. And there are 1 month packages as well that you can look up. And also there are so many question bank, questions, clinical questions you can get. About 25,000 questions you can access with a subscription. And here is boost your medical PG preparation with limited offer. This is 24 months. Get 4 months free. So you get altogether 28 months. So this is going to be immediately added to you. So this is all limited time offer. You have to just use my code. That's all. ROHINI 10. So use this code for 10% discount. And there is also 12 plus 2 offer. That's always there. And you have one nice thing, if you don't want to pay upfront the money, the subscription money, you can also go for EMI. That is minimum of 6 months subscription is what we ask you. The EMI is for 48 months, 1250 per month. And with Iconic, you can pay 1406 and that's for 48 months. Okay, so this is as simple as that. But with a code always, ROHINI 10. So don't forget the code here, students. Please use the code that is for your good and for your benefit. So with all this, myself, Dr. Rohini, signing off and see you all soon with the next class. And don't forget about the special classes tomorrow, Wednesday at 7:30, starting with 7:30 a.m. So you are going to start with your a, B, C, Ds, starting with anatomy A. So you're going to start at 7:30 in the morning. See you then.